Hi, Dr. Yass here. In this video, I want to show the mechanics of the shoulder. Lots of people end up with shoulder pain, and when they seek care from the medical system, they're often going to be told they have bursitis or tendinitis or rotator cuff tear, labral tear, lots of stuff, lots of structural variations. Because it's not shocking that the medical system is designed through diagnostic testing to primarily identify structural variations. And so, the typical type of treatment you'll get is a cortisone shot, or what people don't understand is it's not just cortisone, that it's actually lidocaine injected with it, so it's an anesthetic. So what they're basically trying to do is numb your symptom. And so this process can go on, and oftentimes, you'll be kind of pushed into getting not a laparoscopic, but an arthroscopic surgery to maybe trim off a little bit of the labrum or to correct a rotator cuff tear, any of these types of things. So I thought the best thing for you to do is to get an education on exactly how the head of the arm bone in the shoulder joint moves and what the real primary creator of pain at the shoulder is when you try to raise your arm. If you could understand this concept, this is a core principle. If you can understand how the head of the arm bone moves in the shoulder joint when you're raising your arm, and you get pain as a result of you raising your arm, you can now understand what has to be done to resolve the pain that occurs when you raise your arm. And it has nothing to do with the structures. It's mechanical. It is a mechanical deficit. It is an impedance in the ability of the muscles responsible to allow you to raise your arm without creating pinching in that area. And so if we could understand that principle, then we can understand which muscles need to be strengthened. And through a series of 3 or 4 exercises, you can stop your symptoms and basically alleviate your need to go to the medical system, which is basically incapable of identifying these muscular causes because they don't understand. They're not educated or trained to understand the mechanics of the joint. That's why the only way they attempt to diagnose is through taking a picture, right? Everyone understands this. X-ray or MRI, find some structural variation, bursitis, tendinitis, labral tear, rotator cuff tear, right? Whatever shows up, that's the diagnosis. They don't attempt to understand that your pain doesn't exist when your arm is at your side, but God forbid you try to raise your arm, that's what brings on the pain, and you notice there's limited motion due to the pain. So I wanted to try to give you kind of a dissertation, kind of a understanding of how this works. And maybe if you see the picture, it'll make more sense. And then you'll realize that the ability to resolve your pain is actually much more in your hands than someone external. So what we're looking at here is the shoulder joint. And here's the head of your arm bone. And here's the shoulder joint. So what we have here is, if you see, this is the head of the arm bone. Right here is what is known as the glenoid fossa, and this is your shoulder joint. And this is where your glenoid fossa is. That's the portion of the shoulder joint that's made up by the shoulder blade. So we have the head of the arm bone sitting in the shoulder, at the end of the shoulder blade. Now, we see muscles here, and the muscles that we're looking at here are the rotator cuff muscles. Everyone's heard the phrase rotator cuff. Well, the rotator cuff is basically a group of muscles that attach from the shoulder blade to the head of the arm bone, and it's primarily responsible for keeping the head of the arm bone in the shoulder joint through shoulder motion. Now, if you notice, we're looking at 4 muscle groups. There's the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. So, and here's your deltoid. Okay, so the deltoid attaches from the arm. The front deltoid attaches to the collarbone. The lateral aspect attaches to the spine of the scapula, the acromion process, this portion of the shoulder blade. And then there's a posterior deltoid that attaches to the spine of the scapula, which which is right here. So the deltoid kind of wraps around this way, the three different parts, and all three parts wrap around the head of the arm bone down and attach on the upper arm bone to something called the deltoid tuberosity, okay? So we have it attaching around here, wrapping around the head of the arm bone and attaching on the arm bone, so that when we contract the deltoid, it lifts the arm. This is going to come up. Now, let's go very slowly through this process. If the arm bone is lifted this way out or to the side, the head of the arm bone is going to go up. Because look, the attachment point, the stable side of the deltoid, is above the head of the arm bone. So if I was to take this side and pull it towards this side, this is going to go out, but the head of the arm bone is also going to go up. Well, we have the biceps tendon running through this spot. And if you notice, the supraspinatus muscle, the rotator cuff aspect, runs through that spot also. So if the arm bone is going to be pulled out by the contraction of the deltoid, but also up, anything that's in this space between the shoulder blade aspect, right here, this is called the acromion process, and the head of the arm bone, if the head of the arm bone goes up, this space can be impinged upon. So the supraspinatus tendon and the biceps tendon, which isn't shown, but I can assure you runs through here as well, can be pinched, which is what is typically known as impingement syndrome. Many of you have been diagnosed with impingement syndrome. The problem with the diagnosis from the medical system of impingement syndrome is that what they're going to tell you is that there's a bone spur that has developed at the bottom of the acromion process, and that's what's entered this space between the head of the arm bone and the acromion process or the shoulder blade. So what they're going to tell you is that there's a bony structural impingement impedance, and that should be surgically repaired by something called an acromioplasty, where they're going to shave this out. My position to you is that if that were true, if there was a structural variation by this bone spur, and I had you lay down and I was to raise your arm, well, then that should be impeded because the bone spur is in the space where this arm bone should be able to move. And if it was in there, it wouldn't matter whether the person was trying to raise their arm or an outside person tries to raise their arm, there would be an impedance of range of motion. So whether the motion is active, the person doing it, or passive, someone else moving it, there should be an impedance. And in all the places, the people that I've treated where they were told that they had a bone spur creating this symptom, when they had the limitation, it was only in them trying to move it. There was pain and the pain was impeding it. When I tried to move it, there was no pain and no limited range of motion, which tells you that the space where the arm bone has to move is free. And therefore, the limiting factor is muscular. Okay? So let's ignore, unless you could show me that there is a loss of range of motion, let's ignore the fact that a bone spur was identified and simply say, yeah, it's there, but it's not impacting the function of the shoulder, and therefore it requires no intervention. It's an independent variable. The bone spur was only found because you're having a muscular deficit impeding the normal mechanism of the shoulder, and because the picture was taken at that time, that's why you found the bone spur. But if you never had the shoulder muscular deficit, you would have never found you had the bone spur, and you'd be living your life with the bone spur, right? The bone spur is just like a wrinkle. It exists, okay? But it doesn't require an intervention. So if we understand that the natural way that this is going to work is that the deltoid is going to pull the arm bone out and up, and that will lead to the head of the arm bone rising into this area and possibly impinging against the shoulder bone, this acromion process. Well, mechanically something better pulled down on the head of the arm bone. So as this is being pulled up, something better pull down. Some other muscle that's attached to the head of the arm bone must pull down this way. So if this gets pulled down while this is going out, that stops the head of the arm bone from going up and impinging, which is why the rotator cuff, this aspect is known as a humeral head depressor. Humeral head depressor. So this pulls down. This pulls down. So as the deltoid pulls the arm bone out, this portion, the infraspinatus and teres minor and the subscapularis as a factor, will pull the head of the arm bone down, which stops the opportunity for the head of the arm bone to rise into this area, which is called the subacromial space, the space below the shoulder blade portion, which is above the head of the arm bone, known as the acromion. So if it stops that, then this can pull the arm bone all the way up without ever having impingement into the subacromial space and preventing the pinching of the supraspinatus and the bicep tendon. So visually, we could now understand that the deltoid creates the general raising of the arm, and the rotator cuff, not the supraspinatus portion. Look at the line here. The supraspinatus portion is not in a position to create downward force. It creates a more upward force. So if you said that you had no ability to raise your arm, you had plenty of ability to raise your arm, but just having your arm hang created pain, that would be more in line with the problem of a strained supraspinatus. Because the supraspinatus, if this is hanging down, this is involved in supporting the head of the arm bone or the weight of the arm, right? If this is coming down, this is the muscle contracting, stopping it from coming down. So very important differentiation. The supraspinatus had nothing to do with humeral head depression during the raising of the arm. So this is critical for people to understand. If you get an MRI and it says that there's a rotator cuff tear, and the muscle specifically described, which I have seen in every single interpretation of a MRI of a shoulder, when they talked about a rotator cuff tear, they always talk about a supraspinatus tear. You have to recognize that that is a 100% independent variable if your pain comes when raising your arm, because the supraspinatus can have nothing to do with raising your arm. It has nothing to do with limiting the impingement. It has something to do with helping pull with the deltoid in terms of creating this outer motion, but it has nothing to do with the ability of stopping the head of the arm bone from rising into this space and impinging on the supraspinatus or the bicep tendon. You have to be below, the muscle must be below the head of the arm bone to allow the contraction to pull the head of the arm bone down to impede its upward motion into the subacromial space. So for everyone who's been told that their pain is raising their arm is due to a rotator cuff supraspinatus tear, that is 100% fallacy. It's absolute lunacy. It is simply identifying that a supraspinatus tear has been identified at the time that you're having pain, which is coming from a completely different source. And by the way, that supraspinatus tear that was found is occurring because of the fact that these muscles are not doing their job, and the head of the arm bone is in fact rising, pinching on the supraspinatus, the tendon of the supraspinatus. So the identification of the supraspinatus tear is actually reinforcing the weakness of the infraspinatus and the teres minor aspects of the rotator cuff. They're not depressing the head of the arm bone. So hopefully with this understanding, when you end up having pain with raising your arm and you feel that pinching here, you'll realize that the primary muscle that's responsible for this is weakness of the infraspinatus and teres minor, along with possibly muscles that hold the shoulder blade in place, which allows the infraspinatus and teres minor to pull off the shoulder blade to allow it to pull the head of the arm bone down. So the rotator cuff typically is a factor in creating, in inciting this pain, but it's not a tear, it's a strain. And so if you want to have a better understanding of which muscles are involved, and you want to understand how to perform the exact exercises to address this deficit, then you get the Yass method, because the Yass method is designed to evaluate your situation and determine which exact muscles are involved in creating what is known as impingement syndrome. This is a mechanical impingement into this subacromial space, the space below this bone, where the bicep and the supraspinatus are being pinched. So if you want to speak about this issue, by all means, you can contact me at my email, drmitch@mitchellyass.com, or you can go to my website, livewithoutpains.com, livewithoutpains.com, and there's livewithoutpains.com/sessions, where you could schedule a Yass method Zoom session. Just realize that you could get the Yass method. You don't have to be in person. It's done virtually. I've treated people in multiple countries, and it's highly effective. The sessions are videotaped. We make sure that you understand how to perform the exercise properly. I will perform the exercise first, describing it. You will then perform it under supervision to make sure you're doing it correctly. The session is videotaped. You take that forward, and that's how you resolve your pain. So hopefully this was a really nice tutorial. I thought pictorially that will help you understand what's involved in creating your shoulder pain when you raise your arm and how to properly resolve it. If you like this video, please give it a thumbs up. If you like my YouTube channel, Dr. Mitchell Yass, please subscribe to get notifications when new videos are added. For now, this is Dr. Mitchell Yass, wishing you a pain-free, fully functional life. Bye-bye for now.